This is a case of three-port laparoscopic appendicectomy in a young female patient suffering from acute exacerbations of recurrent appendicitis and also having right ovary adhered with the uterus as per the US report. Now, through the umbilical port, you can see the cecum, the distended gut lobes, and the pouch of Douglas. There is blood collections, POD. There is the blood, and probably this is due to the menstruation blood, and the bladder is quite distended, and entire OT is done under the spinal anesthesia with sedations. And now we are going to introduce the suprapubic 5 port here, and after inserting it through the median umbilical ligament, not to jeopardize or injury any of the inferior epigastric vessels which are just lateral on either side of it. So we are just introducing the 5 port through this, and so it is reintroduced, and now it's out. You can see the base of the appendix which is connected with the cecum. I am just rotating the cecum. The base of the appendix is well visualized and it is very much distended. I can feel with my non-tooth grasper the fecalith within it, the pouch of Douglas. Here we are searching for any adhesions. Now we are going to introduce the third port, which is again a 5 port for traction and counter traction of the appendix, and through which we will introduce our energy source, that is the bipolar shearer, for our dissection purpose. Now we are going to introduce the third 5 port, third port. So entire operation is done under anesthesia with sedations, and the 5 port has been introduced in. Now our first work is the additional lysis and dissection. You can well appreciate the iliac vessels which are pulsatile, and appendix is remaining just over it. So here some abnormal bands are there. This is not a natural band, so I am just cutting it. The bipolar shearer is not working, so I have to change my bipolar shearer. Sometimes the bipolar shearer creates problem, so it is not actual. So it is the, you can appreciate that the color is a difference, and this is the bipolar shearer, which is very much excellent and handy. So I am just changing the direction of the camera and trying to hold the appendix with the grasper at its tip area, and it is quite hard. You can see the difference at the base and the middle and the tip. The dilatation is there, and fecalith I can feel it. So appendicular artery is now ligated with the help of the bipolar shearer, and the mesoappendix dissection is going on with this bipolar, and now the appendicular artery has been separated. The small fibrous adhesions has been cleared off all sides for proper applications of the knots at the base of the appendix. Here 3 to 5 millimeter base is needed to prevent the stump appendicitis later on. So now I am going to introduce the number 1 silk as an extracorporeal Mistra's knot, and the near the base I will ligate it double. That means the two extracorporeal Mistra's knot will be used to ligate the base of the appendix twice, and the distal part of this, after the ligature, the distal part will be bipolarized, and with the help of this bipolar shearer I will cut it and I will extracted it with the help of the endobag. So that there will be no spillage during expulsion, or sometimes you may grasp it with the crocodile forceps near the base, and then you can pull it through the 10 mm port. So I am trying to hold it, but it is through the loop of the knot that has to be introduced. So I am taking the loop through the end of the appendix, and now I have to shift it towards the base so that the proper ligation or ligature has to be properly applied near the base. So I am just taking care of the base. Now I am just pushing the knot and it is tightly attached. You can see the blanch, so it will jeopardize the vasculature also, and now it is cut. So after proper seeing the blanching, you can appreciate the pressure that has been applied through the suture. So it is quite obvious that the appendix lumen has been occluded enough, and you can appreciate that the another ligature is going to be applied here through the same port. The port has been accidentally removed, so I have to reinsert the port, and going to take again another ligature that has to be applied just distal to the previous one for proper application. So another ligature with the extracorporeal knot with Mistra's knot has been introduced, and the tip of the gallbladder is taken care of, and it is snugly fitted enough for proper applications of the knot towards the base. So it's on. Next is just proper ligature at its position. The knot is getting slipped out from the knot pusher, so gently I am taking care of it, and now it is well applied. Again, blanching can be appreciated. Thus the area that has been blanched distal to the ligature has been taken care of. The endosuture is in to cut the sides of the suture so that nothing should remain there. And after cutting the appendix, we will properly delineate the uterus, the ovaries. Here the bipolar shearer is in and it is in action. So small bird is the main key. Make a small distance, few millimeter both proximal and distal, and after proper taking care of, it has been cut. Now the gallbladder has to be extracted out through the 10 mm camera port. Here we use the 10 mm telescope initially, but gradually we will shift our 10 mm telescope with 5 mm 30-degree telescope that has been introduced through the right iliac fossa area 5 mm port. So the appendix is now going to be extracted out through the umbilical 10 mm port. So the crocodile forceps is here. The grasper has been introduced and I am trying to pull it out in such a way so that the end on position has been maintained. So it is out so that none of the toxic material should be spilled out within the abdomen. Now the sucker will in and it will do the job of proper irrigation and suctioning of the toxic materials or fluids due to the appendicitis inflammatory reactions. So sucker is in, sucking the blood at the pouch of Douglas, and it is the menstruating blood, nothing more than that. It is not the fresh blood at all. So I am just doing the suction and irrigation. So suction and irrigation is going on, and thorough peritoneal lavage is the main key for early recovery of this patient, and thus my job of doing proper suctioning is on, and you can see there is no fresh bleeding, because in appendicectomy operation the main function is to prevent the bleeding from the appendicular artery. So that has been well tackled with the help of our bipolar shearer. So now the suction and irrigation is going on, and everything is taken care of regarding this one. So uterus, there is adenomyometric changes you can appreciate, and small fimbrial cyst that has been sucked out, and adenomyosis of the uterus may give rise to unnecessary abdominal pain, and though this female is an young one, it is always advisable for the parents for early age pregnancy to take as early as possible. So proper suctioning is there, no fresh bleeding, only some returning fluid that is also clear. Patient is 15-degree head down position for appendicectomy to do. So here the pouch of hepatoscopic pouch of Morrison, there is some fluid is there, so I am just taking care of this returning fluid. And gallbladder, you can appreciate sea green color, it is well visualized. So I always prefer to do trying to make the abdomen absolutely dry enough, so our job is almost complete. And small area, some fluids are there, I am just taking care of that areas. No more fluids is present there, so just taking care of this hepatorenal pouch of Morrison area. Because of this 15-degree tension position, the patient's fluids are getting collected towards the subdiaphragmatic space. Pelvis is now getting cleared off the fluids. The urinary bladder is distended, so intra just before shifting this patient, we use this nail cath for urine to be properly evacuated, and bladder should remain non-distended, and patients passed urine spontaneously after getting the spinal effect off.